Bonjour, good morning. Je m'appelle Anne Lagacé-Dawson de la Coalition canadienne de la santé. Nous sommes tous ici à la demande de Canadian Doctors for Medicare pour vous alerter au danger que pose la loi 11 en Alberta. Pas seulement pour les Albertains, mais pour tous les Canadiens et Canadiennes, les Québécois et les Québécoises. Et je tiens à vous dire que je voulais vous présenter un de mes plus grands trésors, c'est ma carte d'assurance santé du Québec. Vous en avez tous et toutes une. Et cette carte représente l'accès aux soins de santé sans tenir compte de son compte de banque. So this is one of my greatest treasures, my healthcare card. It guarantees me equitable access to healthcare without taking into consideration my ability to pay. And this concept is at risk as of the passage of Alberta's Bill 11. This card may no longer allow access to medically necessary care if Alberta gets its way, and it will spread across the country. So that's why we're here today, convened by the Canadian Doctors for Medicare, along with our friends at the Canadian Medical Association. And our first speaker is the president of the Canadian Medical Association, Dr. Margot Burnell.
Thank you very much. Good morning, everyone. Bonjour à tous. Doctors across Canada are deeply concerned about the Alberta government's proposal to expand private health care. The Alberta government claims that simply injecting more money into the health system will not improve access to care. Yet, that's exactly what the government is proposing, injecting more funds. Only this time, they're coming directly from patients' pockets and going into a parallel private health system. This plan would take resources away from the public system and create a private option that only some people could afford. That would mean longer waits, fewer available doctors, and more strain on the public system, the one that most people depend upon. The CMA recently spent a year studying health system models across Canada and around the world. What we found is that there are real risks if we move too far toward parallel pay-for-service models. Studies show that when patients face extra charges or when private insurance starts covering services that are already part of the public system, it can actually make inequities worse. It pulls staff and resources away from the public system and drives up overall healthcare spending. When physicians split their time between public and private practice, it tends to hurt performance across the board. Patient experience, provider experience, population health, and value for money all take a hit. It's also worth remembering that Canada is already behind when it comes to public funding. About 71% of our health spending is public, well below countries like the UK and Sweden, where public funding is over 80%. That context matters when we talk about what kind of system we want to build. As part of our research, the CMA also heard from more than 10,000 physicians, patients, and providers across the country. They told us overwhelmingly that they want a strong public health system they can rely on. Physicians, nurses, and other healthcare workers know what really improves access. Training and licensing more health professionals, expanding team-based care, and using technology to make care more efficient. These are proven practical solutions, and they're available to us right now. I join my colleagues here in calling on the Alberta government to reconsider their proposal on Minister Michel and Prime Minister Carney to enforce the Canada Health Act. We have the talent, expertise, and leadership to do this right. Together, we can put solutions in place that will strengthen the public system, because here in Canada, we care for one another, regardless of income, geography, or any other factor. In Canada, no one should be left behind. The CMA stands ready to partner in these efforts. Thank you. Merci, miigwech.
My name is Danyaal Raza. I am a family doctor and a board director of Canadian Doctors for Medicare, a national organization of physicians dedicated to evidence-based values-driven solutions to strengthen our publicly funded healthcare system. Medicare is not just a policy, Medicare is a promise. And it's a promise that in this country, when you are unwell, your care will come based on medical need and not on your ability to pay. And today, that promise is under serious threat. Alberta's Health Statutes Amendment Act, more commonly known as Bill 11, passed this December, and it is that threat. This is why this week, Canadian Doctors for Medicare and a coalition of 23 health and labor organizations issued a joint call to action to the Prime Minister and Minister of Health. In our letter, we are calling on the federal government to act with the urgency that this problem demands. This legislation enables physicians to accept private payment for care that is otherwise publicly covered and publicly insured. It permits sending bills to patients for medically necessary physician care. And in doing so, it creates, for the first time since the Canada Health Act was passed, a formal two-tier system in a Canadian province. And let's be crystal clear about what this means in practice. When physicians earn more in a private parallel system, this is where time, energy, and expertise will disproportionately go. Not for every doctor, but for enough that it will have meaningful consequences. And the evidence on this, it is not ambiguous. International experience, including evidence heard during the decade-long Cambie Surgeries trial in British Columbia, consistently shows that parallel private systems do not reduce wait times, they make them longer. They drain and divert scarce doctors, nurses, and other healthcare workers from a public system that the vast majority of us depend on. Daniel Smith's government has proposed minimum public system hours as a safeguard, but we need to be honest about what that means. It does not work. And we know this not from theory, but we know this from experience. The United Kingdom tried a cap on how much income physicians could earn privately, and it was routinely violated until the government quietly dropped it. Ireland set a limit on the share of time physicians could spend on private patients, and their own Auditor General found it was regularly breached. These are not hypothetical risks. They are documented failures of precisely the kind of so-called safeguards that are now being proposed. Then there's the question of enforcement itself. To even attempt to monitor compliance across the province, Alberta would need to build a significant new bureaucratic apparatus of auditors, inspectors, reporting systems, and legal processes, and this will not be cheap. It is money that should instead go directly into patient care. As the international record shows, you can build all of that infrastructure and still not get the results that you promise. It is wasteful, it is inefficient, and it is a problem that universal public healthcare simply does not have. Today, and in our letter to Prime Minister Carney and Minister Michel, we are calling on the federal government to act with the urgency that this problem deserves, with the full range of federal tools available to them, including financial penalties that the Canada Health Act explicitly permits. By allowing patients to be charged for medically necessary physician or hospital care, Bill 11 is in clear violation of the Canada Health Act. The federal government has both the authority and the responsibility to enforce national standards that Canadians have counted on for 40 years. Silence in the face of this legislation is complicity. Look, we're standing here as doctors, as healthcare workers, and we can see every day what happens when some of our patients cannot access the care that they need. We can see the fear, the suffering, and we know the harm that will come from a system that prioritizes wealth over need. This is not the Canada that we train to serve. Now, it is no secret that there is much work that we all need to do to overcome the very serious challenges our healthcare system faces. And we have the shovel-ready evidence-based solutions worthy of a nation-building project to do this. But let's be clear. We deserve a healthcare system that is universal, accessible, and publicly accountable. And Danyaal Smith's Bill 11 does precisely the opposite. We desperately need some federal leadership that will fight for something better.
Braden?
Thank you. I'm Braden Mans. Thanks for inviting me today. I'm a professor of, I'm a kidney doctor and a professor of medicine and health economics at the University of Calgary. This is a really important issue. While Bill 11 is currently targeted at surgeries, what concerns me the most is this is the thin edge of the wedge. This could be used anywhere there are wait lists, family medicine, specialist consultations. And Alberta might say that the way they've chosen to roll this out is unique, but there's other examples that we can learn from. So we know what will happen if this is implemented. In Quebec in 2005, with the Chiuli Supreme Court ruling, Quebec was forced to create a private for-pay system. But to protect publicly funded healthcare, they restricted physicians as either fully in or fully out of the public system. Alberta's willingly stepped in, allowing not just private for-pay, but also physicians to work in the public and private system in the same day. So in my clinic, I could see new public patients, publicly funded patients who've waited for 9 months to see me, but I might save 2 to 3 spots to squeeze in people who've waited 1 or 2 weeks if they're willing to pay me 4 times as much. Premier Smith says that allowing private for-pay surgeries will make public wait times shorter. Is that true? Sadly, we live at a time when we continually forget the lessons that history has taught us. We've got evidence from Quebec, Manitoba, and other countries that tells us that parallel private pay systems divert scarce health workers away from the public system and they increase public wait lists. So in Quebec in 2017, so after the Chiuli ruling, many private for-profit clinics have been set up and some were doing public work, publicly funded work, and there was a lot of double billing going on. And when Quebec banned that in 2017, around 80 specialists left the public system to go fully private. So prior to 2017, 80% of publicly funded joint replacements were done within 6 months, 80%. Now it's around 30 to 40%. Public wait times for those specific surgeries have risen significantly. In Manitoba in the 1990s, for a period of years, dual physician practice was allowed for cataract surgeries. About half of cataract surgeries were done by eye doctors who worked only in the public system, and about half of cataract surgeries were done by surgeons who worked in the public system, but they also had a private clinic where they did private for-pay surgeries. And within a few years, the average wait time was around 10 weeks if you were operated on by a public-only cataract surgeon. The wait time was 4 weeks if you paid privately, and the public wait time was 23 weeks for those same private eye doctors. In fact, a private for-pay system doesn't work if you don't allow your public wait times to rise. I'm not going to be willing to pay 4 times as much unless there's a significant discrepancy in how quickly I move forward in the healthcare system. Other countries tell us the same thing. In areas where there's more private pay surgeries, Australia, the UK, public wait times are longer. So we've actually already got an example of what's going to happen in Alberta. In 2021, the government doubled down on contracting out low-risk surgeries, the exact same low-risk surgeries that are now you're going to be able to pay for out of pocket. And that essentially does the same thing. It diverts cataract surgeries, knee replacements, hip replacements, the same ones that are going to be available private for pay. We've diverted about 2,000 more per month. But governments take a 4-year view of healthcare, and they've done a very poor job of workforce planning. So we've got half the physicians as other countries that offer private for-pay surgeries. In Alberta, that means fewer OR staff, fewer surgeons, anesthetists, and they'll be diverted away from the public system. But some surgeries, like heart surgery, cancer surgery, are only done in the public system. Now, prior to 2021, around 2/3 of cancer surgeries were done within the target time, the target wait time. Now it's less than half. The other thing that this is going to introduce is that insurance. There's going to be people going to be able to insure for this. There's a reason why we have a single payer system. It's a much more efficient way. So in the US, for instance, they spend twice as much on administrative costs, insurance overhead, and then the government administration you need to manage the insurance system they spend around 8% of their healthcare system's dollars, whereas we spend about 2%. That's a complete waste of resources that are not going to patient care. So to be clear, I want to acknowledge there are problems, long wait lists, some patients waiting 10 times longer than others, but there are evidence-based solutions to long wait lists, and let's choose those instead.
Good morning, and thank you to Drs. Burnell, Raza, and Mans. My name is Jason MacLean, and I'm chair of the Canadian Health Coalition. It was founded in 1979 by the father of healthcare, Tommy Douglas, among others, to protect and advance the universal public health care. Today, the coalition represents more than 3 million Canadians, frontline workers, provincial and territorial health coalitions, civil society groups, and researchers. We also represent the mainstream Canadian public opinion of the overwhelming pride in our healthcare system. We take care of each other in Canada, something that clearly differentiates us from the United States. Our coalition played a key role in getting the Canada Health Act put forward by Monique Braden, the then Liberal healthcare minister, and it was passed unanimously in 1984. We're here today to denounce Alberta's Bill 11 and its multiple violations of the Canada Health Act. As you have heard from our doctor friends, the bill is a terrible new development and is creating a United States-style two-tiered for-profit healthcare system. This is why Tommy Douglas and so many others push forward on the Canada Health Act and a universal public health care program that provides care regardless of ability to pay. I want to mix in some good news with the bad. Even though they're dealing with underfunding and privatization of the Ford government in Ontario, the Toronto General Hospital is ranked as number 2 in the world in Newsweek's rankings. It's recognized as a top publicly funded hospital globally and a top hospital in Canada. We Canadians did that together. We helped to make that happen. Our leaders, our federal provincial taxes, our publicly funded medical schools and universities. Our public schools are the foundation that built that success story and so many others. The dedication and skill of the doctors who are here with us today and the thousands of other physicians and allied health professionals, many of whom are members of my union, the National Union of Public and General Employees, and other unions, are the building blocks of the excellent and life-saving care Canadians have and deserve. Bill 11 is a direct threat to those achievements. It violates the Canada Health Act's requirements for public administration, accessibility, and universality by allowing wealthier patients to jump queues and by enabling extra billing. That is why the Canadian Health Coalition is calling on Federal Health Minister Marjorie Michel, Member of Parliament for one of the poorest and most densely populated ridings in Canada, to use her ministerial powers to prevent Alberta from taking the rest of the country further away from universal public health care and towards private for-profit two-tiered health care. I want to return to the first principles. We did not get this beloved program of healthcare by some fluke. It was the CCF, the precursor to the NDP, the Liberal Party, the labor movement, civil society groups, faith groups, and many doctors, and they campaigned and they fought for it. Since the beginning, private for-profit interests have constantly worked behind the scenes to tear down our public universal healthcare system. Douglas and the founders of healthcare knew that. Those profiteers and those profitizers have made a lot of inroads. For-profit interests are campaigning to dismantle and privatize. They exploit any crisis and underfunding, which they lobby to create to push their agenda. They saw an ideological opening with the Alberta government and they moved in. Our research shows that the insurance industry has been working closely with the Alberta government on Bill 11 and has a large working group of industry representatives inside the Alberta UCP government of Danyaal Smith. The public was not consulted, doctors were not consulted, but the insurance company was front and center. There's at least 18 private insurance lobbyists registered in Edmonton, and it looks like they had a direct hand in drafting this bill. We just heard international evidence that shows that countries with higher level of for-profit care have worse health outcomes and higher mortality rates. When profit plays a bigger role in care, people, which are our neighbors, our friends, and our families, they fall through the cracks and they don't get the health care that they need. I'd argue that any government that diverts to a lesser form of health care should be held criminally responsible for any negative outcomes. This is negligence at a minimum. Policymakers like Federal Health Minister Marjorie Michel must use her power to strengthen public health care now. Because Bill 11 isn't just routine reform. It's a deliberate attack on the principles Canadians built Medicare on, care based in need, not ability to pay. If Ottawa allows Alberta to proceed, Bill 11 becomes a blueprint for others, and the damage spreads far beyond Alberta. My message today is simple and firm. Enforce the Canada Health Act, stop privatization, extra billing, and queue jumping, and stop Bill 11. Canadians built Medicare together, we sacrificed to achieve it, and we will protect it together. Thank you.
So we'll take any questions, if there are any questions.
Thank you, merci. Nous n'avons pas de questions pour le moment. We don't have any questions. This concludes the press conference. C'est ce qui conclut cette conférence de presse.
Merci. Merci à la tribune de presse. Thank you. Thanks, Braden.
Thank you, Braden.
Thank you.